Hello, my name is Cheyenne, and I'm going to present to you a case study of pathogenic potential. Today, I will cover the patient's history, clinical presentation, diagnostic results, and the treatment and resolution of the bacterial infection. First off, we have patient information and history. In May 2024, a 57-year-old female presented to the trauma emergency department following a fall at home. The incident resulted in a left tibial plateau fracture and a left proximal humerus fracture. Her left lower extremity was stabilized in the emergency department pending further evaluation by the orthopedic team. Current patient history is as follows: a retired paramedic with 20 years of service, history of hypertension, asthma, a previous smoker, and a history of recurrent lung infections. This patient was hospitalized 1 month prior to the fall for acute respiratory failure in April 2024. Immunizations are currently up to date. Now we will go over the clinical presentation of the patient. The patient was hospitalized in the trauma ICU from May 8th until June 6th. On May 10th, she underwent surgery to repair the left tibial plateau fracture with placement of a Stryker Pangea proximal tibial locking plate. At closure, the orthopedic surgeon applied a vancomycin-tobramycin mixture to the wound. She received 2 units of packed red blood cells, and the remainder of her hospital stay was unremarkable. After discharge, the patient entered a rehabilitation center for physical therapy. When insurance denied continued inpatient rehab and wound care, she was sent home with home health services and support from her daughter. Over the following 2 months, however, the surgical wound gradually began to reopen. As the wound continued to worsen, the patient presented to a local emergency department for evaluation. She was treated with clindamycin and 10 days of oral Bactrim and discharged home. Any guesses about which bacteria might be responsible for the patient's persistent wound infection? If you were thinking of Corynebacterium species, you are correct. The wound culture later returned positive for Corynebacterium striatum because it was initially interpreted as a gram-positive rod of low significance. No further workup was performed at that time. The patient developed increasing pain at the surgical site, accompanied by redness, swelling, and warmth. The wound progressed to tunneling with hardware exposure and wound dissonance. The patient was admitted for an IND, during which the surgeon excised non-viable tissue, repeatedly irrigated the wound in hardware with saline and diluted betadine, and applied an antibiotic mixture of Synthicure combined with 1 gram vancomycin and 160 milligrams gentamicin before closing the incision. Aerobic, anaerobic, and tissue cultures were sent for laboratory testing. Infectious disease was called in for further treatment of the patient's opportunistic infection. Graphic images to follow. The first image is around 6 weeks post-op. This is also when the stitches were removed. Shortly after the stitches were removed, the wound began to reopen, as seen in the second image. The home health nurse believed the incision was healing from the outside in. The next set of images show the onset of worsening symptoms. You can see clear wound dissonance, significant inflammation around the knee, tunneling, and exposed hardware. Though the wound was showing active infection, CT scans seemed reassuring there was no deep surgical site infection. The final image is after debridement and stitch removal, a much prettier picture. Next up, we will discuss result analysis. Here are just a few laboratory results done the day before the IND procedure. Although the white blood cell count is not elevated, it is on the higher end of the reference range, and you can see inflammation markers are significantly increased. Microbiology reports from the IND showed no organisms on the gram stain. This may be due to prior antibiotic therapy suppressing bacterial numbers. Both tissue cultures demonstrated light growth Corynebacterium striatum. Here's the susceptibility testing and a short list of antibiotics given during part of the IND treatment. Daptomycin and minocycline are the antibiotics of choice for treatment. The patient had no previous success with vancomycin. Perini is typically a multi-drug resistant bacteria. The best for last, the resolution of the patient. Usually with Curani infections, the hardware is explained, but due to the nature of the break and poor bone health, this was not a surgically feasible option at the time. Once susceptibility testing came back, the patient was referred to infectious disease for further treatment. A PICC line was placed for at-home IV therapy, and the patient received 950 milligrams of daptomycin every 24 hours for 6 weeks via PICC line. After completing IV therapy, the patient transitioned to 100 milligrams of oral minocycline twice daily for 6 months for continuous suppression. While being on these high-dose antibiotics, it is vital for routine blood work to monitor organ function. These labs included CBC with DIF, a BUN, creatinine, hepatic function, CPK, and CRP. This case highlights the importance of laboratory monitoring, as long-term minocycline therapy can lead to side effects such as thrombocytopenia. After nearly 11 months of continuous antibiotic therapy, the patient achieved a complete and successful recovery. Here are some Corynebacterium factors to consider. Corynea is found in normal skin flora and considered a common culture contaminant. Biochemical testing of Corynea, you will find it is catalase positive, maltose negative, and CAMP test positive. On gram stain, Corynebacterium species appear as non-spore forming gram-positive rods arranged in Chinese letter formations. Corynebacterium species grow on chocolate agar and sheep blood agar, typically forming small pinpoint colonies on sheep blood agar. Attached are photos of Corynebacterium growing on chocolate agar and the growth of Corynea on sheep blood agar. This was 24 hours after incubation at 37 degrees Celsius. The second image may look familiar from our slide on gram-positive rods. You can clearly see the Chinese letter arrangements. This bacteria can also appear in Y, L, or V-shaped patterns. Thanks for watching my presentation on Corynebacterium striatum. So you may be wondering how I was able to access so much clinical information about our patient. Well, the patient is my mom. After years of working in the clinical laboratory with only occasional bedside experience during my time in phlebotomy, I suddenly found myself on the other side of patient care. When my mom had her accident and I became her sole caregiver, I gained a new appreciation for the responsibilities and challenges of direct care. Because of my laboratory background, I already understood the importance of aseptic technique and the risk of secondary infection if proper wound care isn't maintained. I had to learn how to manage our PICC line, perform daily wound cleaning, and pack and dress the wound correctly. This experience strengthened both my clinical skills and my respect for the work done by bedside providers.